Sometimes before you even start a case, you already know that the capsule is going to rip. This is one such case with a very high interlenticular pressure. I tried my best for decreasing the interlenticular pressure in this patient by giving him preoperative Diamox 300 cc IV mannitol, but to my to my belief, I already knew that this Rhexis is going to rip out. As soon as I gave my first small nick, the capsule just went ahead with the 180-degree rip. I was not able to salvage this, and you're going to face challenges similar to this situation later on in life if you're a high volume surgeon like me in India. Hi, this is Dr. Semanchal Goyal, and as you can see, what I have now is a Rhexis runout situation, an anterior capsular Rhexis runout, and now I just have two ways to go ahead completing this surgery safely. The first one is to straight away convert this patient to SICS. I uploaded a video a few days back to my channel where I completed such a case where the nuclear grade was grade 4, grade 5. It was a brown cataract, it was a hard cataract, and I changed my strategy and converted this case to an SICS in that video. But today, our approach will be different. I'm going to use a very novel technique called as horizontal carousal in this patient, and I'm going to complete this case with a phaco. Completing such a case in your early days using a phaco is a little bit challenging, and I would suggest that you have an experience of around 1000 cases in your surgical career first to take on a case like this with a ordinary phaco. You can use this technique safely once you have sufficient experience in phaco emulsification. And as you can see, I have sped this video up. I'm just making my Rhexis a little bit bigger so that there is not a risk of the anterior capsular rip going to the posterior capsule, because this is a weak area in the 6 o'clock that you see. There is the capsule is deficient over there and it has gone to the fornix. But in my experience, I have noticed that a lot of these tears rarely go behind in the posterior capsule. Yes, these rips rarely go in the posterior capsule if you are careful enough by not increasing the intralenticular pressure. At this time, what I'm doing is I'm just emptying the bag so that my chops don't rip the posterior capsule. You just empty that bag up and you bring the nucleus up into the anterior chamber, and just like this, it's a prerequisite for an SICS and it's a prerequisite for my horizontal carousal technique. You should learn this move. I'm going to slow it down for you guys, and all the surgeons in life are going to face a situation like this, a Rhexis runout situation. And as you can see, I'll hold the nucleus. I have slowed this video down. I have made a continuous phaco mode and high vacuum, high flow, and just like this, zoom, zoom, zoom. You just keep your pedal in the phaco 3 position, and just like this, nucleus is going to spin like a top. This is so beautiful. The bag is empty. You're not producing any stress on zonules, any stress on the Rhexis rip, and there are negligible chances of a Rhexis runout situation going to the posterior capsule and ultimately leading to a PCR. This is the safest technique in my experience. I have salvaged a lot of cases of mine by using this technique. This is a beautiful carousel. If you want to see this maneuver again, you can go ahead, rewind this video and just learn this technique. You just grab the nucleus from the edge, you increase the vacuum, switch the continuous mode so that the nucleus melts down in front of your phaco tip. And just like that, we are down to the last liquefied cortical remnants that are the culprits of a raised intralenticular pressure. So this was a very fun. It's a beautiful case to demonstrate you how you can salvage even a Rex's runout situation. This is a Rex's runout situation. White cataracts are fairly common in certain parts of the world where patients are not educated enough to come to us in hypermature scenarios. But yes, once they come ahead, we have to help them out. And as soon as I saw this patient in my preoperative time on a slit lamp, I knew that the Rexis is going to run out. I have done a fair bit of hypermature cases, but some cases stand out with their very high intralenticular pressure. It's a doctor's duty to take a high risk consent from these patients. I always take a high risk consent from these patients, explaining them the risk of posterior capsular rupture and a subsequent risk of a lens drop. And the patient agreed to that consent, and to to our faith in God and to the expertise and the experience that I have gathered over past couple of my years in ophthalmology, I was able to complete this case. And I see a fair bit of comments in the comment section pointing out fingers at me and saying that I should have done this and that to complete that Rexis safely. I should have completed a baby Rexis first and then enlarged my Rexis. I should have done this. I should have used a fair bit of Visco. But guys, I am not here to admit that I am the maverick of surgeries. I am here to show you how you can correct your complications that you may encounter in your life. All of us must come to the terms with the fact that complications are a part of a surgeon's life, and a good surgeon is the one who can who can just give brilliant results to the patients despite all the complications that you have. At the end of this video, I'm just going to point out one single detail, that I have kept the haptics aligned with the anterior capsular rib. Just don't keep them 90 degrees away or perpendicular to the rhexis rib, because it can lead to an continuation of rhexis rib, because as soon as the haptics open, they are going to lay stress on the rhexis rib, and in some cases it can result in a posterior capsular rib as well. So I have kept the haptics in orientation or around 10 or 15 degrees away from the rib. This is a safe place to keep the IUL. So that's all from my side. I hope you like my videos. This was a very interesting case on how to handle a Rex's runout situation. The patient eventually had a brilliant outcome from a hand movement vision to 6-9 in the postoperative period. This was an Ayushman patient. We operate these patients free of cost in India under Pradhan Mantri Jan Arogya Yojana. Prime Minister Narendra Modi has changed lives through this scheme. That's all from my side. Thank you so much. Have a great day ahead.